and make those embers glow. I'm on my way, and I don't skip a beat. I can't help it, I've got happy feet. So good, I do what I want and it's understood. There's no stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. You know what I mean. I'm on fire. I'm feeling glad there's a spark in my soul. Feel my heart go zing. I'm clapping my hands and I'm pulling these strings. No stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. I'ma do me. You know what I mean. You know what I mean. I'm on fire. Yes, I am. I'ma do me. I'ma do me. You know what I mean. You know what I mean. I'm on
I'm steady walking like I got 3 commas in my bank account, living loud. So get your cameras out. I'll probably do the same thing if I was you. Looking at me now, now. Put up your lights and keep them flashing. Don't ever put them down, down, down. Look at me now. Look at me now. Look at me now. Good God, I'm looking sweet. Right now I'm feeling like a slice of heaven, and you wanna sink your teeth in me. And the way that I move my feet, it's like I got this whole world spinning round to the rhythm of my heartbeat. Put up your lights and keep them flashing. Don't ever put them down, down, down. Look at me now. Look at me now. Look at me now. Look at me now. I feel so good. I feel so money. I feel so good. I feel so money. Look at me now. Look at me now. Look at me now. Look at me now. I feel so good. I feel so money. Look at me now. So good. I feel so money. Look
I can't seem to focus, and you don't seem to notice I'm not here. I'm just a mirror. You check your complexion to find your reflections all alone. I had to go. Can't you hear me? I'm not coming home. Do you understand? I've changed my plans, 'cause I'm in love with my future. Can't wait to meet her. And I'm in love, but not with anybody else. Just wanna get to know myself. I know supposedly I'm lonely now. No, I'm supposed to be unhappy without someone, but aren't I someone? You're so handsome, but I know better than to drive you home. 'Cause you'd invite me in, and I'd be yours again, but I'm in love with my future, and you don't know her. And I'm in love, but not with anybody here. I'll see you in a couple years.
It's been a little while since I've looked in your eyes and walked that bridge to the other side. Mama says it's gonna get cold in the night, but if I picture you, then I'll be alright. I am ready. I am ready for you to be here. It's been a little while since I held your hand, so my arms won't stretch to your distant lands. Give me every person in the whole wide world, and I'll pick you out in a second, girl. I am ready. I am ready for you to be here. For you.
Exactly, you'll start to see sometimes do that surgical instruments that I use for atraumatic extractions.
I'm just quickly point that rationale is this.
Hello, everybody. This is Evening DJ, Dr. Mark Kwan, once again coming at you from my studio. Okay, today is what, episode 19? Can you believe it? Episode 19. Thanks for joining, everybody. Okay, we have over 20 joining in live from all over the place. Okay, Scott, the usual such suspect. We got Scott. We got Paul. All right, and who else is here? Eugene is here. Okay, good, excellent. Michael. All right, thanks for joining. Okay, excellent. So please shout out. Once again, you guys, if you want, you are entitled for 1 CE AGD approved credit. Okay, all you have to do is shout out. For example, Mark 1, Vancouver, and also at the end of the coffee show, I'll give out the verification code that you can use to email Grace at info@biceinstitute.com and to earn your 1 single CE AGD credit. Okay, fantastic. So tonight the topic is extraction, socket graft, and implant, and we're gonna talk about it. And we also have two incredible friends, Dr. Nekky Jamal, the Jamalian, and also Dr. Sangwoo Ham, the Sucking Man. Okay, not the Rocket Man, Elton John, but a Sucking Man. Okay, inside joke. Okay, excellent. Yeah, so the topic socket grafting, we decided to do a little bit of a coffee show because a few reasons. We've been putting a lot more emphasis on socket grafting than ever before when we're training our residents at a comprehensive implant residency program. And also, my personal had a revelation on how much socket grafting is so important. When I start to teach immediate molar therapy, I come to a dummy on that about 5 years ago. That immediate molar therapy is actually just a socket grafting with the implant inside. Okay, so it's one of the very important, one of the most important in my opinion, surgical part of implant therapy, but it's one of the most underrated. Okay, underrated because when I ask a doctor, do you know how to do socket grafting? Everybody seems to say yes, but then when they show me the result, it's not always 100% turn out the way they imagine it to turn out. Okay, so we're going to hopefully cover that through a fun evening coffee show tonight. Okay, all right. So I appreciate everybody joining in. What did I do today? Today, like as always, today's a Sunday, and the weather in Vancouver was amazing. I was talking to Nekky today, and they said it snowed. Okay, it snowed in Saskatchewan. I was also talking to Albert, and it snowed yesterday, right? But Vancouver, okay, our weather was unbelievably good, right? Today we had 24, 25 degrees Celsius, which is like a summer, basically, weather. And I took my daughter and my wife, and we go to our favorite spot, Deep Cove. It's about 30-40 minute drive from where I live. It's a short getaway, but it's a beautiful little place. And Osaka is a Japanese restaurant that I love to go. Of course, the restaurant there cannot serve patrons indoor, but the patio they can serve. So we got ourselves a patio, had some tempura, some sunomono, and picked up gelato ice cream for my wife and Unji, right, Alice. So we had a great time. Okay, so today is this topic here, and we're going to introduce Dr. Nekky Jamal and Dr. Sangwoo Ham. Okay, all right, and Nekky is already on. Okay, Rockin' Man, the Socket Man. All right, excellent. We got 26 right here. So let me turn my switchboard, okay, onto an interview mode. All right, Nekky, the Jamalian. Welcome, and the Socket Man,
Yeah.
Sangwoo, Socket Man. I should play music. Socket Man. Na, 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 na.
When did I get that nickname?
Socket Man.
I thought I named you
sounds
Hamburger.
Second man.
For some reason, my name gives me a lot of different nicknames, like hamster, hammerama, hamburglar, socket man.
Hamburglar.
Hamburglar.
Stealing all those hearts.
Anyway, all right, second
I
man
love you,
and
Nekky, man. Love you,
Jamalian.
man.
Okay. Okay, let me just turn this part right here. Okay. All right. Okay. So, well, thanks for joining, guys. Okay. Yeah. So, how you been? Okay, Nekky, we had you in as a guest like a couple weeks ago, right? A couple weeks ago, and you're joining again. So, I appreciate that. Okay. Sang, how about you?
This is me, my new Sunday morning evening session.
There you go. There you go.
It's a routine now.
It's a routine now. You know, like you got this decked out setup in your basement now, right? All this silicon. You're serious about, going to YouTubing, are you, Nekky? Tell me.
No, I'm just getting into rapping, and I need a good, microphone to rap with, and that's my hobby. So I'm loving it.
Goodness. Your favorite artist is what? Drake? Drake?
Of course, it's Drake. Who doesn't love Drake?
There's a rumor. Tell me if it's true or not. You're starting a separate surgical center, okay, near
That's
your
right.
office, and you're actually gonna call the surgical center a Drake
Drake's
Center.
Dental Studio.
Drake's Dental Studio.
Maybe he'll come to it. I think I got something here. I think
Oh
it'll
my
be good.
goodness! Oh my! Now, are you allowed to? Does a college allow it there using somebody's actual name? Like,
Nah,
but the
I'm
Drake,
kidding, I'm kidding.
Drake, but Drake can be anything, right? I mean, like it's a singer's name, but Drake is a like
Right.
a herbal medicine Drake, right? Drake roots too, right? So I think that'll be okay,
yeah.
right?
No,
Awesome.
it's because it's the DDS. Like we're all dentists. DDS. Drake's Dental Studio. That's where it came from.
Oh goodness!
Oh.
Fantastic. Oh, you know what? Michael, he says, Sensei, stick to the implant, bro. No more singing. Okay. All right. I'll take your advice. But I did order a karaoke machine at Bice Institute that we're going to place at a new center, right? Because Kevin, my CAD Chem guy, he loves singing. So I said, you know what? Sometimes like we spend like every week at least one evening treatment planning R2 cases, and sometimes like treatment planning that takes like till like 9 o'clock sometimes, and we get hungry, we order food. So I figure, you know what, do the treatment planning, order some food, have some beer, and sing karaoke at the Bice Institute, right? Okay, so I thought
So there's
that was
going to
gonna
be a PlayStation
fantastic.
5 and karaoke.
That too.
What else we would have?
Right? So it's all planned
I've
in,
seen
man.
what happens when you guys drink beer.
So good
You
luck
guys all
with
turn red, and I'm the last one left.
So that's it. That's good. Good luck with your Drake studio. Looking forward to that. That's gonna be fantastic. How about you, Sang? What you've been up to?
Nothing too serious. I got invited to have another lecture, so I'm just kind of struggling to get that going. So that's another thing.
Which one? The module 3?
The module 3 and the digital dentistry with Megagen. So that's another lecture that I'm preparing for.
Oh yeah,
later.
Yeah.
That's gonna
right.
be another one. So
Yeah.
So it's a bit of a busy week. It's a busy week. I'm getting all the lectures getting together, and I got the study club coming up. I don't know, the live surgery for socket grafting again.
Well,
it feels like socket grafting, but
you are, like Michael Conway said, sucking man, right? Okay.
What happened in that live surgery? What's going on?
Right. So
Just
that's
because
great.
I missed a session.
Fantastic. Now, like last week, one of the biggest event was like Medit launching their i700, right? I mean, like that's been one of the hottest talked about on the social media, because Medit been working on this new sensor i700 to finally take over the trios, global market sales and things like that. So I got my unit. Okay, Sangwoo, you're waiting for yours as well, right?
Yeah, I can't believe you got yours before me.
Yeah, I got mine, man. Okay, so I got mine, but yeah, it's fantastic. You'll get it. I think you'll really, really like it. Some of you guys were asking, what's the big difference between i5 and i700? Speed is one thing; it's super fast, but the sensor is bigger, and which for me will make a difference because it will help me with better scanning of the full arches. Okay, because when you have a smaller sensor, it's actually harder to do that. But when you have a bigger sensor, it'll be a lot easier to stitch those things at a high speed. So yeah, that was exciting as well. So let's turn out. Oh, Chris is here. Chris is here. Okay.
Oh, hey, Chris.
Hey. All right. Oh, Richard is joining us too. Okay. All right. Excellent, Richard. Fantastic. So let's turn our topic to socket grafting. Okay. The good, the bad, and the ugly. Because for me, like I've been doing socket grafting since the day I graduated dental school. That's like almost 25 years, right? But to be honest, that I didn't quite understand socket grafting until about, I would say, about 8 years ago. 8 years ago, right? Because there's something happened, right? When I started like purely implant center, which is about what? When did I start my crystal implant center? It was about 12 years ago. One great thing about doing the same thing over and over and over again, right, is because you get to see your cases repeatedly at a high volume. And I got to kind of find out, looking at my own cases and honestly evaluate what worked and what did not work. And to my surprise, one of the most inconsistent outcome was my socket grafting. Okay, my socket grafting. And over the years, that started for me, starting about 8-9 years ago, to really look at what makes a socket grafting work. And because at the end, socket grafting should be able to do one thing, right? Okay, preserve socket at its best, right? At its best, at a consistent basis, right? And it's the consistency that I had a hard time with, right? Okay. How about you guys? Like socket grafting. What was your story, and how has it evolved, and what's your thought process, right? Okay. Tell me, Nekky, because Nekky's been doing this thing longer than Sangwoo has been, right? Maybe Sangwoo never had any failure socket grafting, but Nekky, I know you for sure had those situations where you put bone in there, and then you suture it, and 2 weeks later, patient comes back, you look in, and then everything's like gone, right?
Yeah, absolutely. And I think it came from because we didn't know how to cover it up. And so I remember we used to get bone. Do you remember, Dr. Kwan, from Rocky Mountain Bone Bank in those big plastic tubes?
Yep.
And I would shove that in there, not even curetting the socket. So, you pull the tooth, leave the granulation tissue in there because you don't know you have to remove it.
Yep.
And then you pack in the Rocky Mountain Bone Bank. You paid a couple $100 for it.
Yep.
And then you find, a collagen membrane. You paid a couple $100 for it.
Yep.
Leave everything exposed, one cross-link suture.
Yep.
And you got your patient coming back in 2 weeks with a big infection and pain the whole time, and they're swearing at you. And it's a real practice builder.
Yep.
And and we've I've learned the hard way, because like that we didn't know any better back then, and I didn't even know where to turn. I thought this is what everyone was doing, and until I took PRF, that's what totally changed everything in my mind. And you talk about what I know, what I wish I knew now that I wish I knew then. That's incorporating PRF really changed the whole game and set the stage of how I need everything to heal, right? So that's what got me on the road to success, big time.
Yeah, for sure. No, I agree with you. I think one of the problem that we had was in my early career is that I really believed that my success was almost entirely based on what product I use. And it certainly was, because when I was a young surgeon, like 26 years old, out of dental school and starting to do implant dentistry, and we didn't have organized, structured institute like Bison Institute in this country. And a lot of it was basically you look at the distributor, their suggestion, what to do, take a tooth out, put that in, put a collagen membrane over, do a suture, like following a Lego a building process, and you do it.
Recipe.
And then 2 weeks later, and then that membrane's gone, my bone is gone, and I'm going like, what the hell happened, right? And then I talked to another surgeon, the surgeon will say, the reason is you're using the wrong membrane, or you wrong bone. So I buy that stuff too. The other stuff that I bought is running in the refrigerator, right? Get other membrane, and then I do that, and then 2 weeks later, same shit happened, right? And then I call up the membrane guy. You said this box says the membrane's supposed to last 2 months, right? Okay, 6 to 8 weeks. mine only didn't even last 2 weeks. And then they said, well, your suturing technique is wrong. You should take more courses, right?
Yeah.
Okay. So that's been around, right? I never really, it was like a chasing my own tail for longest time. That was my, probably the next few years after I graduated dental school, right? And then later finally realized that, it's not the product, it's the biology, right? And that's when the light bulb goes up, right? How about you, Sang?
Yeah.
Okay, were you always the sucking man from the beginning? Okay.
I think a lot of people heard I think a lot of people already kind of knows my story from live surgery because I complained so much about you and Dr. Jin the other day. It's
Time to make me look like a bad guy, right? Yeah.
Oh, I'm not making you look like a bad guy. You are a bad guy anyway.
Tell the truth.
No, but I think I'm lucky because, unlike you, Nekky, or Dr. Kwan, I was pretty introduced by a PRF to get go, right? Like I was with Dr. Jin, I started with him, and PRF was the course that I started bites with, atraumatic extraction. Your course, Nekky, PRF, and then I got into it without really knowing the benefit of PRF. I just did it just because I thought it was a standard. I didn't have to get experience with the non-PRF era, And then for those of you who are listening, there's 30 people already. But anyway, my life surgery study club that Dr. Kwan and Dr. Jin runs every Saturday. My first year, out of 5 sessions, I did PTSD, real story. I did socket graft for 4 sessions out of 5. Socket grafting only, open membrane, closed membrane, open membrane with non-resorbable, resorbable, suturing the heck out of it. And then just as story short, the biggest one was I think I did a beautiful job suturing with the membrane, and then I was giving a patient a post-op instruction, and Dr. Kwan walks in, tells me to freeze the patient up and rip all the sutures out and redo the whole thing again. After 3 hours of suturing the heck out of it using 2 packs of PTFE sutures. I still remember, okay?
Yeah.
I got PTSD from that. I sometimes walk out of the office,
Yeah.
But you know what though? The thing is, once you learn it really, really well, it's other things falls through, it just makes sense, it doesn't make the whole difference from there on.
Yeah.
And so if you ask me, have I experienced a lot of failures? Not yet. Emphasis on the word yet. But I think that's because I had the benefit of learning from a lot of the clinical cases and perhaps things that we didn't know from before, and now that we know better. So it's I think I'm a bit fortunate that way. But it's that's my journey. This is where I started.
Yeah. No, I remember that story clearly, and I gotta be honest with tell you. You guys have, everybody says that, I was the mean guy and, ripping your suture out and doing it again. But the reality, the culprit behind that wasn't me. I was just told to do what I was told to do. I did what I told to do. It was Dr. Jin. Dr. Jin, after he sees you finishing your case, I exactly remember that case. It was a 1617, two molar extracted, everything cleaned out. He did the bone graft, and he put a collagen membrane over, and he did wonderful figure 8 sutures and everything, right? And then Bernard comes out. He goes, Mark, can I talk to you? I said, yeah. Because, that he used the collagen membrane, and I don't think it's going to stay. That thing's going to disappear in 2 weeks. Yeah, so what? What do you want me to do? Go and rip it out. Why don't you go and do it? And he said, I work with the guy. I can't do it, right? So I said, because you want me to go and do it, right? Okay. So I go in. I said, okay, Sang. He was giving post-op instruction, right? And then I tilt the chair back. Okay, let's learn something, okay, right? So I removed that suture, and when I cut it off, his eyes just went big, just big like this, right? What the hell's going on, right? So basically, I told him that, you gotta get a closer primary closure, otherwise the membrane is going to disappear, right? Okay.
The case worked out great, though. The case worked out great.
Yeah,
it worked out great.
But it's
you learn from it. You learn from it.
Absolutely. Okay, so Bernard, if you're listening there, it's your fault, man. Okay, all right. and LSS at that time was like a boot camp. Like we used to really be hard on our LSS doctors because LSS was created to harvest our own faculty. And Bernard had a vision that you and Chris was going to become a faculty from the beginning. We had a sense that you guys had this this incredible intelligence, but also dedication. You guys want to be good, and you guys weren't ready at that time, and you didn't know what our plan was. 3 years later, but Bernard and I, we already talked. We said we're gonna build these guys, and we're gonna build our future around these two, right? And Nekky was already going into from a junior, moving into the next level, and we needed other young faculty for the future. So that's why we're so harsh on you. Love hurts sometimes, man. Okay, love hurts. Okay?
It was fun though. It was fun.
Yeah.
Chris and I would agree that we had a lot of fun.
LSS is if it doesn't kill you, it will make you stronger. I guarantee you that. Right? Okay, tough love.
We're
man.
LS is so much nicer now.
So much nicer. We are more refined. Okay, we're more refined. All right. So yeah, we have 23 here. Okay, we have Dr. Bernard Jin joining as well. Okay, if you have any question, today's very casual. We got wonderful two clinicians who's been through the process, right? Like Nekky, who was the beginner who didn't do any implant, and now he's gone through the steps where he's know enough to teach this very topic. Dr. Nekky Jamal, who are taught by Dr. Jin through Bice Institute, sticky bone, and all these, now is at the high level of extraction, surgical, and he's one of the premier lecturer when it comes to PRF and sticky bones. So you guys have two of the best of Bice Institute can offer. Okay, so I'm going to switch off the screen. Let's go over some case reviews, and because we always fun to discuss these cases here. Okay, all right. So this is Nekky's case, right? Nekky, what do you have here for us?
Well, I figure the Hamburglar would talk about socket grafting. Now for those that don't know much about me, my entire practice is based around extractions, and that's how I've built my practice, and it's worked, awesome. And all I do is sedation and take out teeth, and I have a lot of fun doing it, and I wanted to share some tips and tricks with you.
How did it start though? How did it start though, Nekky? Like, what did you always had a affinity to surgery, or because you're a general dentist, and I know you have like a huge general practice, right?
Yeah.
How has it evolved? Because some of the younger doctors are asking like, what drove you, motivated you, and when did you know that you're gonna do what you do now?
I always found I had a knack for helping anxious people relax. And maybe it's my personality. Maybe I just joke around a lot and I don't take anything too seriously. But I was always able to calm and reassure patients. And then patients started, referring their friends that haven't seen a dentist in 20 years. And maybe it's from drug use, or maybe it's from anxiety, or whatever. And then I started sedating people, and one thing led to a next. And I started seeing people that would travel 6-7 hours just to come and see me, even though they had dentists in their own town. And we would, take out wisdom teeth, or we would do full mouth extractions. And then we started, doing locators at the same time as those extractions. And I was able to grow my surgical practice through anxiety and through anxiety relief. And there's, everyone's scared of the dentist. And so we just, I'm not that smooth.
Who was that? I think that's Bernard.
I can tell already. And then, I volunteer a lot throughout the world and doing dental trips, and it really helped build my extraction skills and providing a service to the world. And I'm excited to share my tips and tricks with you today after tens and thousands of wisdom teeth extractions. And I know we're not talking about wisdom teeth, but did you guys know the very first tooth I pulled in private practice, I put into the sinus?
Amazing.
Yeah.
I'm impressed by your performance.
Teaching you today. That's right. But I tell you that because I've failed in everything. And if it hasn't happened to me yet, it's coming tomorrow. And so I want to share my experience with you because I don't have an ego, and I want to share with all my failures because that's how you're going to learn, right?
Absolutely.
And so, and just like this first video I'm going to show you, how not to pull an upper first molar. Because man, these are everyday extractions, but they can go south really quick. And you know, a 10-minute extraction will turn into an hour extraction, and now you're behind all day. And these aren't practice builders, and this is not how I want to treat patients in my own practice. But yet, this is a video of me doing just that. So
perfect.
Yeah.
Let's go to the next slide.
Let's get right into it. This is an upper first molar, and this is a full mouth clearance case. And you know, the sinus was riding pretty low, and I wasn't at work today, so I didn't give you guys a radiograph. But my favorite instrument for taking out teeth, 3mm luxator. And
I
know
that
a lot of people that's my main go-to, and everyone has their go-to. But I love my 3mm luxator. Some people love spades, like, you know, the 60B from Titan. That thing's awesome too. But look what I'm doing here. I elevate a little bit. I'm in a rush. You know, my patient's sedated. You can see that the C-sponge there. And I just take my 150 and I just try to luxate the tooth and, you know, expand the alveolus with my 150, because, you know, I don't have time to section. And you know, I'm going at it pretty good. I think I have some you know, movement here. I don't need to do any. Look at me reef on this. But look, I got it loose, right?
Wow.
Bam. I got the distal buckle out, and then I have 2 roots broken.
Oh yeah.
This is not what we want to do. This is the worst thing you can do, because now they're broken below the bone. And now what? How do we get this tooth? If I was going to do an immediate implant here, I'd be sweating pretty good, because now I have to drill away my bone that's going to give me my initial stability.
Oh, you see,
and so here,
Sang will just put a socket graft over top of it and grow a bone.
That's right.
Bridges. Socket shield 201.
Oh yeah, I never thought of that. This would be my socket
So
shield.
now you're digging it out. Right?
Now I'm digging it out, but this is not what we want to do. You can see the palatal root there, and how do we get these teeth out? Well, the only way is to start taking away bone, but where do we take away bone? Where's the best place to take away bone? I know in my hands, building up lingual bone is brutal. I don't know how to do it. You know what? I'd way rather build up a buccal plate any day than mess around on the lingual. But I know that furcal bone is the most important if I'm going to be putting an implant in there. So I don't want to drill all that away, because where am I going to get my stability from, right?
But not only that, when you have a low sinus, when you're drilling the septal bone, you can puncture through the sinus too. I've done that enough times too, like an idiot.
Yeah.
You know? Yeah.
We all done it.
When you have that bone riding so low and you start drilling away bone, and now you're trying to dig out roots. That sinus is right there, and it's so easy to push that tooth in there. And you know what? I'm lucky that happened to me so early in my career. That it's always, I hear myself in my head, don't be an idiot, don't be an idiot, don't be aggressive, because this is what can happen, right? And then now I got to take out the mesial buccal root. I have nothing to luxate around. I need to create space, because creating space is how we take out teeth. Sometimes it's, you know, removing tooth, sometimes it's removing bone, but I need to make space so I can get rid of that mesial buccal root now. But look at the mess I've created. This is the last thing I want you guys to do. And this is all so preventable.
Don't worry. I've seen Sangwoo do that all the time at LSS. Making a mess all the time.
But we gotta agree though that it's not it better happen in the upper than lower, because if the lingual plate's broken in the lower, now you're fishing through the floor of the mouth. That's just not fun. That happened to me.
I've been there a couple weeks ago, and I was I lost the roots down here, and I actually fished her right back through the hole. So
this is a problem with me too, right? Like, people think that, oh, Dr. Kwon, you make everything look so easy. Yes, but you know, monkey falls out of tree too, right? And the problem is overconfidence, right? Dunning-Kruger, right? You're overconfident. I go in there and I rush through the extraction. And that's when the shit happened, and that will slow me down. It's like a quicksand, right? And I got another patient waiting, I got a consultation, waiting for me, and all this, and it's like a domino, right? So for me, what I've learned is early a stage is that take my time with an extraction, and if I do it, take my time, I end up finishing quicker, right? Because I don't have to. But
not only that, you don't see that patient next week for the oncoming complications that are going to come. So taking that extra, 10 minutes with your extraction saves you that oral antral communication that you may see in the next coming weeks,
For
right?
sure. For sure. Yeah, we've all learned.
Especially
yeah.
in these scenarios here. And so, maybe I was rushing and I didn't even bother to take PRF before I even started.
Yeah.
And I just think the blood clot's going to take care of it.
Yeah.
And so these are all little tiny errors that build into something huge.
Yeah.
And this is why I always teach, do things slow right off the bat, take your time and be consistent. Always have your formula of what you're going to do, and your assistants know what's coming and they set up for it. You know what I mean?
Yeah.
So I'm a huge fan of that is just, taking your time.
And I think Bernard is there to he'll agree with me. We're talking about the socket grafting because we did a few socket grafting session at the LSS just yesterday. He and I were talking about, how socket grafting has evolved over the last 27 years that we've been doing, because what we were taught to do after extraction is actually crush the septal bone and crush the buccal plate with our fingers.
Really?
Yeah. Because a lot of our, when we were graduating, we needed that ridge compressed, and we believe that by doing that, it will prevent from stuff getting inside, easier to suture, and it will heal faster so that we can give them dentures. Okay, so what we were taught to do at that time, our primary goal was to prepare the ridge for the denture. Nobody really talked about implant, in a dental school, and how it has evolved over the last 2 decades for me and Bernard was that, destructive surgery no longer. Now it is a constructive surgery, is implant dentistry, right? And this whole concept of socket grafting, start to evolve, more of a preservation and constructive, form of a surgery to later on to receive the root form implant and the prosthetic subsequently. So like for me and Bernard, it's actually quite a one extreme to another, right? We rode that whole wave for the last 2 decades, right? So it's kind of really interesting, right? Okay.
Absolutely. But even now, like I'm a general dentist, and we don't have, a lot of us, and I know every single person in Bites right now, we don't have the implant center that you and Bernard do. This is everyday dentistry. How big do we feel as dentists when we bust off the buccal plate of a canine, of an upper canine, and you're permanently deforming that patient's ridge? And you can feel it with your finger immediately. And you know that they've lost a pillar of their face because you rushed. And so this is
Sangwoo knows Sangwoo knows about that all the time. He does it every day.
Yeah.
Hey, I did it last week.
Not anymore.
I was the thing last week, man. It just happened last week. I was just like, I still remember this right here. It was just moving. I remember it.
So like we understand how important extraction is now, right? Like things that we just rip it out and take it out, and then we lose some bone. What's the big deal? But now that's not how we think of it. The way we think of extraction, the concept of atrial extraction is actually really, really, really important. Really, really important. Right.
Absolutely. Yeah. And for me, it really comes down to, I can take out any single rooted tooth, but I can't take out a multi-rooted tooth. So for me, I always feel like if I'm going to take out a tooth with, as minimal trauma as possible, I'm always making multi-rooted teeth into single rooted teeth.
That's right.
And then for me, it's just, a game of chess to see which root wants to come out first. Right.
Yeah.
And so I automatically section the crown, and there's a couple ways to do this, and depending on what everyone's been exposed to, I'll just tell you my 2 ways to section an upper molar. And the first way involves removing the crown, and I really feel like you have to remove the crown in order to get all the way to the furcation with your burr, because I think that's the number one error people have is they just jump in there trying to section that tooth right through the crown, and they think they're all the way through the furcation. They stick their luxator or elevator in there, and they just crack off the crown, and now they have a root that's below the bone. And that's the number one error I think we all make. And if you haven't made that yet,
guilty.
Well, you haven't been practicing long enough.
Guilty.
I 100% agree. And until you learn from that extra minute of just cutting the crown off, so you can see what you're doing, you can get to the furcation, that right there, that tip is worth its weight in gold, because that will save you hours in your week.
Absolutely.
Yeah. So you need to see what you're doing. So you need to see that frication. So the first way
Mm-hmm.
is I always remove the crown. And the trick is you don't remove the crown at the gingival margin. The trick is to remove the crown right below the contact. So you leave a little bit of what I teach and what I call the handle. You need a handle to grab onto teeth. You need a handle to take out that tooth. But if you section that tooth too low gingivally, you have nothing to grab onto, right? So I always like to make my section right under the contact points. Does that make sense?
Oh, okay. Gotcha.
Yeah. What do you think, Sang? What do you do?
I'm guilty of this, but I do actually exact opposite. I actually don't cut up the crown personally, unless
Really?
I have to. That's just me being lazy. At first, I was being lazy, but then what I do is like just below the contact point. I never thought about that, so I think maybe I'll try that. But it just gives you more leverage personally. But it's because for some reason I find that especially with a 3 mm luxator, man, that thing changed my extraction technique. 77R used to be my favorite, not anymore. That thing is amazing, but it's but I do tend to cut really deep, so it's because there are times I'm guilty of not cutting deep enough that I'm trying to chop bone to get the bone out, tooth out.
Let me tell you why. Okay, let me tell you why. Your burr, the most common burr that people use in their practice, I would say, is either a 557 long or 701 long.
That's right.
The shape of that burr, when you go cutting through that crown, the sides, the shank of the burr will actually bind along that crown.
It binds.
Because it's wider than the cutting edge. So then when you go to drill deeper, you think that you're all the way through the furcation, and you're not.
And you're not.
And then that's when you crack off the crown. And now you're in trouble. Then you have the exact same problem I just showed in that video, right?
I have my
so if you want to save time, you cut the crown.
Yeah, that's exactly
You want me to share my secret how I do these?
Please. Yes.
I'm not gonna share it. I'm gonna keep it. I'm gonna keep it a secret.
Here we go.
I use a two-drill technique. And I'll tell you how I do it. This is the easiest way to do a coronectomy and easiest way to section it. It takes me like 5 minutes and the tooth is out. You want to know?
Let's hear it.
I'm not going to tell you.
Okay.
It's okay. Nekky can take. I know Nekky can take out too faster than you can, Dr. Paul, so I don't care. I know this is Nekky, okay?
Okay, let's go. So coronectomy.
He had us going, and then he just realized he does the exact same thing. That's cool.
Hey, as long as I get you guys going, man. Hey, I'm not the star. I'm here to learn, okay? So I like that. Right under the contact point, I think that's really, really important.
I think that's good because you give me leverage to elevate and also, but you get enough visualization.
I tell you my secret. I'm not going to tell you my secret about section. I'll tell you what my secret is. Once I section it, power elevator is my boy.
Absolutely.
He's my bad boy.
Yeah.
I love that boy, okay? That thing, that's amazing stuff, right? Okay. So tell me about this slide right here. Okay?
So I think a common way people like to section their teeth is to do the P symbol or the Mercedes-Benz symbol. That's what we hear of all the time.
Yeah.
But in my experience, the hardest root to remove is the palatal root. So the less tooth that we give that palatal root, the more that we're going to break it off. I think the mesial buccal and the distal buccal, especially the distal buccal root, is usually the easiest root to remove because it's the smallest. Usually mesial buccal is the most curved. But if we give more structure to the palatal root, that will allow us to get it out. And I always think that the palatal root is the hardest, and I remove it last because then I have more space to get at it.
Yeah.
So my tip for the palatal root is exactly what Dr. Kwan just said. If you want to use the power elevator, that thing is money with palatal roots. It literally just jumps right out of the socket. There's no question.
Yeah, because a lot of people say, what's the difference with power elevator and physics forceps? I used to think that they were just very similar. More and more I use it, they're quite different. They both use a leveraging, but the power elevator, one of the key features, they got a bear claw. So even you only have like a 1 or 2 millimeter, it'll grab it.
Yeah.
And second is that it can rotate both direction, right? Because it comes in a pair, right? So you can go buckle and like if I'm doing elevating out the rotating out the buckle, mesial buccal and distal buccal, I use the bear claw the other way. And if I'm doing a palatal buccally, I'll use the other bumper, right? So I think it's fantastic. It's one of those instruments that more and more I've used more and more I understand the instrument. So it's a fantastic. Yeah.
And I hear a lot of questions like, are power elevators the same as a physics forcep? And they're not.
No, they're not. They're not. Yeah,
No,
they're both
because they can be
leveraging.
used on both sides.
Exactly. I mean, the mechanics might be, but there's so much more things are different on a power elevator
Yeah.
that
More
we can
versatile.
do. Yeah, more versatile than physics, right? Yeah. Okay. So you do this one here,
Yeah.
and then what do you do next? Which one do you take out first? Okay, out of these three routes.
I like to take out the mesial buckle and distal buckle first. Now, whether whichever one, the distal buckle or mesial buckle, comes out first, it doesn't matter to me. But I always leave the palatal to last. And the palatal, I find, if you have the ability to grab onto it, if you don't have a physics forceps, using a 150 and getting deep down the root, make sure that you're putting apical pressure on your 150
Yeah.
and then rotate. There's
Yeah.
no left or right or buckle. You
Yeah.
literally rotate that tooth out.
Yeah.
If you have a physics forceps, that's what you use
Yeah.
for the palatal. But getting that palatal root
Yeah.
is what gives you the satisfaction of walking away, and that's your mic drop elevator moment. That's
Right?
right. Because
Pop.
man, nothing brings you more satisfaction. It's like
Yeah.
a little dopamine rush every
Oh,
single time
no.
that palatal root pops out, right?
And you right? You know you won.
Especially with the
Yeah.
physics forcep. It's
That's
just like,
right. You know you won. Yeah,
you
exactly.
won.
With the physics forceps, right?
Yeah.
Yeah.
The sensation is undeniable. It's undeniable, right? No,
It's-
you just
That's
feel
why
it.
I
It's like
hate
pulse and
ortho.
it comes right out.
So
See,
mesial
ortho
buckle-
sucks because you have to wait 3 years to get
Mhm.
your satisfaction.
Mhm.
With extractions here,
If not
man,
longer.
it's like within a minute. Here we go.
Yeah. So Sang, you do the same thing? Mesial buckle, distal, and then palatal, right? That's what I do too.
Kind of, but I do a little bit similar, but
Yeah.
slightly different. I actually section in the middle first and elevate right away. Because
Mm.
just like we said, the palatal is the hardest one out.
Mm.
My rationale between is that the medial buckle and distal buckle together
Yeah.
can give a little leverage against the palatal. So what I do is I do the mesial to distal sectioning.
Mm.
I do a little bit of luxation with the elevator, and then I finish up the sectioning afterwards, so that it gives a bit of a luxation against the palatal.
Ah, okay. That's
Then-
two. Yeah.
then-
Yeah.
That's just the one step I do, and it makes things a little easier. So that's just.
Mm.
But then it's just more of a preference than anything. But essentially the same way. Essentially
Yeah.
the same way.
That's
I
right.
learned from
You know-
Nekky.
Yeah.
The one thing that we're not talking about here is when we do go to take out those roots all at once, is how often does that buckle plate come with it, especially in softer bone, right? And I think we've all been there. And
Yep.
if you want to take out teeth fast, you either
Yep.
bust the roots off or break the buckle roots off.
Yep.
Or
Yep.
buckle plate off, sorry. And it's
Yep.
going to happen. So
Yep.
why not preserve? As we
Yep.
always say, the tooth is, if we're taking out the tooth is ours, the bone is theirs.
Yep.
Like, you got to keep that bone in place, right?
Yep. Yeah.
Mhm.
Now, let me be a devil's advocate though.
Yes, sir.
You were taking this out, and I'll draw this arrow right here. And let's say that it broke right here. Right here.
Mm-hmm.
1/3. Okay. This thing comes out. Okay. Here. And these are not budging. What
Yeah.
do you do? You got to remove something. You
Ooh.
cannot remove the roots anymore. This whole tiny little thing happened. You got to remove bone.
Yeah.
Where are you going to remove it? Where are you going to remove it?
What do you think? Where's the most important bone? What do you think?
Okay. I'll tell you exactly what I do, but I'm not going to tell you right now. So, Sang, okay, I'm going to put you in the
Oh,
corner.
Dr.
Okay.
Kwan.
Now tell me. What would you do? Right?
I just showed you a video on
Personally-
it, man.
No. But that you came out, you rescued it. But there are cases that you will not dig out. You got to remove bone. You got to remove
Yeah.
bone.
So
And I want to put
so
implant in here. I want the immediate implant in here.
That's right.
Oh, immediate. Okay, that's a whole different story. But
Okay.
that was the question I was gonna ask. So, for immediates, man, I do. If it's an immediate, what I tend to do if it's a buckle and distal buckle root,
Mhm.
is I actually make a window, just a little cock eye, just a little bit of an apical incision, just like an apicectomy,
Mhm.
and just push it from the apical up, because that's easy to do.
Mhm.
But then when I feel like I'm very I want to be a little bit MacGyver-like, I
Mhm.
get that 45 size 45 finger
Yeah.
endophile.
Yeah.
If there's enough canal, I engage it and I just luxate it comes out.
Give me
too.
a
Those are
break.
two ways I tend to-
Endophile. Endophile my
Oh, yeah,
ass,
it
man.
worked.
Once in my
Endophile
career,
my
man.
ass. Root like this?
It worked.
Ah,
As
come on.
I said, if I feel like it,
I don't
if
buy
I feel
that.
like it, I just said that.
I don't
Oh,
buy
trust
it.
me,
That
works,
root
I don't
has
man.
to
buy
be
It works,
super
man.
loose.
No.
That root has to be wiggling in the wind.
It's
Oh, no,
stuck.
no.
This thing is
No.
stuck. Okay? I'll tell you what I do.
I-
And it's going to be controversial.
But
And
I
I'm
do
not-
make a decision, so.
And I'm not going to.
He's gonna drill through the buckle.
Oh, he's gonna make a big flap. I know. He's gonna bust up the buckle plate, take it out, place the implant, and just build it right back up. That's exactly what Dr. Kwan's gonna do because that's faster and easier.
That's what I do. I don't bust it out. I deliberately make a window here.
Buckle window.
Buckle window, and I get those out, and then I rebuild it up. Right? Okay.
That's what I just said.
Rebuilding the
That's what I
buckle
just said
is
too.
so predictable.
Buckle is way more predictable than interproximal. Okay?
Absolutely.
Yeah, and a furcation rebuild, when you drill the furcation area, there's no more good bone for me to put my implant in there, right? Okay. So, because those things do happen, and just telling you what I do, right? Like I said, I'm controversial. Now look at here.
But
Yeah.
Dr. Kwan, the upper is different than the lower. Because you
Oh
would
yeah,
do that
whole
on the
different
lower.
story.
Lower? Like doing
Yeah.
what? For what?
You're not going to, because that buckle plate down near the roots, if you break like, a 2-millimeter root off
Mm-hmm.
and it's deep down there, that
Oh, yeah.
buckle plate is much thicker.
Oh, I use
You're still gonna
endophile
go
for
through the
those.
buckle
I use
there?
endophile for those.
Oh, yeah.
Okay. Oh, let's bring this up.
Okay, tell me
What
instrument.
other tips you got us for us there, Sang? What other tips you got?
Oh, I got lots.
Hey, I tried it. It worked. But I don't use it that often. But usually I just make a window, just like Dr. Kwan said, just like pop it right out. It just
Okay.
takes 2 seconds. Take it out.
Yeah. So what instrument to elevate with? You already said your favorite
I already
instrument,
said
right?
3-millimeter luxator. And
Yeah.
there's so many different ones out there.
Yeah.
I really feel like it's a must-have in everyone's toolkit.
Yeah.
3-millimeter luxator.
Yeah.
And then the second one, I'd say what everyone would really like, and it's gaining more and more popularity, is the spade elevators.
Yeah. Yeah. Or is the
Absolutely.
same as approximator, the spade approximator?
Well, yeah, as Sang proximator is a Sang proximator. Did I just name approximator after
Yeah.
you there, Sang?
Okay.
Yeah.
Sucking
Me?
man, right? One that you tap,
But-
right? The
but
spade
then-
tapper.
But
Yeah.
But I gotta say, do you agree that if you get a 3-millimeter approximator, like I personally I used to use spade all the time. I don't use it anymore. 3-millimeter luxator works every day.
3-millimeter is my go-to.
Yeah, it's just like I used to use
3-millimeter
spade all the
is my
time, but I
go-to.
don't use it anymore.
I
don't use it.
use peritom spade a lot still. A lot.
Really?
Yeah, a lot.
I don't use it anymore.
I
I don't
only
like
use-
peritoms, man.
I use 301 and power elevator and peritom. Those three I can take up pretty much anything. Yeah. Yeah.
That's
So,
what I
but
used to use, but 3-millimeter
Yeah.
luxator, like that's a game changer.
maybe I don't
older
agree
as
with
well.
you because I never used the one that you guys use, maybe, right? Okay.
Yeah.
But again, like everybody has but the mechanic, I think extraction is similar. Instrumentation
same,
might be
I think.
different, right? Okay. Very good.
Absolutely. And like the old school way of going at
Yeah.
teeth would be, to come at it from 90 degrees.
Yeah.
And that's how a traditional elevators use. And now
Mhm.
a minimally traumatic ways to come at
Yeah.
it along the long axis of the tooth, like we
Yeah.
would a luxator.
Yeah.
And so I think the instruments have changed the way that we take out teeth.
Yeah, I think it also like me and Bernard, we were so heavily utilizing Proximator in my early career. It just we just our life depended on it, and it's still I think Bernard, like he said right there too, be easy on distal proxies. He likes a full set of proxies. I only use one spade proxy. But we use proxy quite a bit. Okay, right. Nekky, thanks for sharing that case with us, right? Okay, because we all been there, done it. Let's not fool ourselves. Extraction sometimes can be our worst nightmare of the whole procedure, right? Sang, what you got here for us tonight?
Just like I just brought 3 cases actually. This is just actually the socket graft case where actually I guess I coordinated this one. Just looking at what I said.
The truth comes out.
Oh.
Crown popped out. Yeah.
It kind of popped out. So it's just a regular day-to-day socket grafting, but it's this is one case where I intentionally actually had to socket graft. Like I was gonna go for immediate, but then this is one case where the bone was actually soft in some areas, and where it shouldn't be soft, it was soft, and where I don't want it to be soft, it was not soft. It's and it just was, I think it was an 80s elderly lady. It was and patient wanted to get implants, but she couldn't afford it right away, and the vertical root fracture. So you can clearly I sectioned it, take the tooth out, and this one was an open membrane technique of the DPTFE membrane, not an EPTFE membrane, DPTF membrane, and people has to know the difference because open membrane. I think Dr. Kwan would agree that open membrane technique became more popular with the DPTFE membrane introduction, not before.
Yeah.
But of course, we used to use resorbable. I think some cases resorbable works great. Some cases not. Here, I use DPTF membrane because at least in molar sites, I think DPTF membrane works more predictable than the resorbable. Not that the resorbable doesn't work, but then this one, just a plain old straightforward just socket preservation or alveolar ridge preservation according to academics. And then that's the picture on the upright. It's the post-op. Just the suture removal after 4 to 5 weeks, and then and the 4 month post-op in the bottom right. So I think I preserved quite well, if anything. And then
that's the one beauty about this open membrane technique in combination with a dense. D means dense. Okay, dense. And when Sangwoo, I don't know if those audiences understanding this, but early on, the early generation non-resorbable Gore-Tex membranes had a perforation in them. Okay, perforations. And later they found out that it actually caused more problem. So now the new ones, I think they only sell now dense one, which is non-perforated, much better barrier, and that actually revived this open membrane technique. Because it's an old concept, but it came back, and it gives us a far less possibility of an infection. And one thing about this open membrane technique that especially like a Sangwoo's case is you get beautiful keratinization. That's one thing.
It gets soft tissue.
Undeniable, because you don't get something like this with a closed membrane technique with a collagen, right? So
absolutely.
Yeah. So,
hey, Sang, I got a question for you. So, go back to So
this
I
one?
get this question a lot. No, go to the.
Oh, the other one. Yeah,
there. Yeah. So if you look in the top picture there, like where your beautiful suturing is, how much bone are you putting in there? Are you making a little mound? Are you making it flat off? Like how do you put your bone in there before you put on the membrane? Because I get a lot of people asking me this, and I say, well, ask Sang.
Nekky, come to the course. Come to the course.
Yeah.
Well, you'll be at the course anyway.
I'll be there anyway. Man, how do I do this?
Sangwoo can answer that. I can answer that too, right? Because that was
it's like a big. It was like a big discussion analysis.
I'll tell you. I'll tell you. I mean, Sangwoo will go over that in detail, but it really comes down to our objective when we're doing these type of open membrane technique. Because now 2 things has to happen in order for every open membrane technique to work. 2 things. Principle of biology. One is there must not be space between the membrane and the bone underneath it. There must not be
That's right.
space.
No dead space.
Yes.
Yeah.
When there's space, we call that a dead space. And when there's a dead space, if the bacteria gets in there, right, the body cannot get rid of it. So in order to get rid of dead space, initially you need to overpack a little bit so that allows the adaptation of a PTFE to be nice and tight. And doing Sang's compression suturing technique, you can really compress that downward and eliminate the dead space. Okay, so but
that's a huge pearl right there.
Okay, all right. So
I'm
not gonna tell you more because Suckin Man is gonna tell you everything later. Okay, but like what we teach, right? What Sang's lecture is about is that he focuses on the biological aspect of it. Why when socket grafting doesn't work, why it doesn't work, right? And it's following the principle of the biology is going to make it ultimately be successful every single time, right? We're trying to teach the doctors, okay, what criteria you need to follow in order to make it right? And number one reason why in the past PTFE open membrane failed is because they're creating dead space without even knowing it, okay? So eliminating dead space is absolutely important. Would you agree, Dr. Ham?
Yeah, because one thing I do like to highlight, or I should say, like just emphasize on the grafting is that, because I'm guilty of this too before, but then a lot of people think that grafting is different for socket graft, lateral ridge, like immediate implant, but everybody heals the same. And socket angiogenic novel growth, Doctor, just going on, but it's like I treat socket grafting just like immediates, so that's how I like to treat them. Like, well, as we say, like immediates are like socket graft, and to me, socket graft is like immediate. I like to see I like to graft as if I'm doing immediate implants. So it's I think that will answer a lot of the questions, especially if people are more experienced with the implants.
That's one of the most important things that you taught me, Sang, is when I started going back to this DTPFE, is I always used to make my bone flat. And there would be that space, and I was having that failure, and people would come back 3 weeks later and say that they had pain, and then you pull off the membrane, there's purulent exudate everywhere, right? And so until I learned to get rid of all dead space, and that has to do with suturing, and that has to do with making sure that the bone is in contact with that membrane, it makes a huge difference.
No, it does. It's a little things that makes difference, and what I like to share with people is that what you do here is not just socket grafting, but preparing for immediates later, right? So it's like what Dr. Louis did a month ago, it's and Dr. Kwan did like in the first session, like the grafting is the same to me. It's you're just adding bone to the people, so but following the principle is what's important.
And we have to understand this too, right? Like when you look at this slide right here, this tells us everything about socket grafting. 6 weeks later, you remove the PTFE. And look at Sang's patients right here. There's a little granules here. This is like a dual zone grafting where this is not going to turn into bone. That extra bone that you piled up in like an ice cream cone, our objective is not to think that that's going to turn into bone, right? No. Body will get rid of the any bone that's outside the biological bony envelope, okay, graft envelope. But what it has served is to get rid of a dead space. And part of this will become soft tissue. Part of this will become underneath the new periosteum, and it's going to become corticalized once again, right? And eventually, it will heal by secondary intention, and which is a kernization of the occlusal surface, right? So it's the biology of it. We're not really growing bone. Body's growing bone. The question is, how of a good of a condition can we give it to our body, to the patient, so that it can do what it's supposed to do? Because a lot of surgery that we do, socket graft, unfortunately, we're hindering body's ability to heal rather than promoting, right? Let's talk about this one here, because this one's significant.
Yeah, this one is a interesting one. Patient came in. She actually didn't want implant. She didn't want implant. She wasn't convinced because her family members, a few of them had implants apparently elsewhere, and then had a implant failed miserably. Not in this province. They said Alberta. I don't know if you know, but but it was not. I don't think it was anything bad, but it's just mishap for anybody. But this infection was a little big because you can see that the inferior alveolar nerve is essentially touched. There's barely any cortication on one of the root area there. Is it you? So this one was a little nerve wracking because when I went in, I couldn't take photo because it was just more sedation. I couldn't see it, but then I think I felt the inferior alveolar nerve too. And this is where the essentially good debridement and trying to get the good bone graft, because I did bone graft anyway for the patient, because I told her if you ever decide to get an implant, at least it preserves something. Now, this one is a little controversial. Would I have gotten bone without bone grafting? Probably yes. I probably had lost a little bit of bone in the buccal, not too critical, but I still did a socket grafting in this area. I didn't really document this so much just because this one was a tough one to deal with. It's one of those where it's sedate and the people still fight you a little bit. I'm not certified like you, Nekky. I can't use fentanyl on this one, so it's I had to fight a little bit, so got it done. But it's one of those where good debridement is important, because if you go to the next slide, patient came for follow-up. I did take a CBCT patient. They don't want it yet, but the bite wing will show that like the bone level is just right there. It didn't go down more apical or anything. It's quite dense bone. I think that's 2-year post-op. But it's trying to preserve what it is. But that's just one of the things where good debridement is important for socket grafting. And then this one is where everything comes down with implant complication management. But then it's kind of a socket grafting.
It's a different case.
So it's a whole different case. This one, whole different case. So this patient was referred to me. This was placed by a different dentist about 3 years ago. And then patient, if you can see on the picture on the left, it was purulence, but then the dentist couldn't figure out why that happening. So it was stent. So I took a CBCT. Apparently, patient doctor didn't take a CBCT afterwards. But you can see the bone loss and the bone loss around the implant. And basically flapped it open. It's and then this is patient. I actually suggested taking the implant out. I think Dr. Kwan and many of the faculties would agree that it's much easier to take the implant out and then start over again, and then trying to salvaging it. I really tried hard to convince the patient, but patient did not want to get the implant out and tried asking me to try to salvage it. So this is where the in a way socket grafting 201. It's where the debridement is essential for the grafting to work. And I put the before and after, not because there's so much different, but I just want to highlight that the one concept we talked about, a dual zone grafting, or adding enough bone so to get rid of dead space. You see, if you look at the PA at the bottom, and then if you look at the PA on the top, you will see a little bit of the peak of bone that was built up around the implant fixture. It's that's not bone. That's not bone. It's not turning into bone. I did not grow papillary bone, but that's more bone that's embedded into gingiva. But you can see that soft tissue profile around the implant fixture after healing on the right side. That essentially I did a socket grafting with the healing above but not. Now this is a little controversial way of treating the implant, but essentially it's a socket graft to me. Debride the area, get rid of the infection, add bone, and body will do the rest. And it's just something that I wanted to point out with this case.
Excellent. That's it?
Pretty easy.
Can't be it.
Nothing
Can't
too.
be it. Let's talk for another hour.
I don't want to make it.
That's it.
It's one of those things where it's nothing too crazy. It's not an implant complication lecture, so I'm not gonna go over how we're gonna deal with all this. How to debride, how to clean this area, what chemicals I use, and how I do it. That's like another session. That's gonna make me do so many things. But
Sang, I got a question for you. How often do you socket graft with sticky bone versus just normal bone right out of the syringe?
Normal bone right out of the syringe?
Yeah, like how often do you make sticky bone to do a socket graft versus just using?
You mean like
just straight up granules?
Is it possible to use like normal bone just out of syringe?
No,
Why
you know
not?
what I mean.
But
When do you how often are you making sticky bone?
Every single time. Every single time.
Yeah,
if I'm taking two sets to
single time.
implant, even patient might not need it, I'd rather take a red and a white tube and just have it ready to go, man.
Absolutely.
I
do
do
not.
One thing I do different.
Yeah.
One thing I do different. I'm sure Nekky knows, and Dr. Quad knows. I do make the density different though. Density of the sticky bone. That's one thing I do for the.
Me too.
So it's depending on the cases. Like I mix a little bit of PRF. I make it sticky, but some cases if I think the bone graft is not there I don't need that much bone density to keep the space up. Then I actually prefer PRF with a less dense bone to get a more viable bone. But then in certain cases, I make it dense.
Did I tell you that I have a sticky bone density D1, D2, D3, D4 fabrication?
Okay, I didn't go that far.
I haven't taught you guys yet. Okay, when you're doing sinus, you need your sticky bone density to be soft.
That's right.
Okay, so I have a different combination. When I'm doing veneer grafting, my density has to be a little denser. When you're doing Santa grafting, it needs to be super dense. When you're doing vertical, you got to be super dense, right? Does Santa
work that well? Like I just haven't had experience with it, so I don't know. But like it looks like make things so much easier, but
Santa
just doesn't look that easy.
Is a unicorn. Gotta chase that dragon, man.
Oh.
Okay. Santa it is technique sensitive, but once you follow it, and the key is implant positioning and getting that sticky bone really, really nice and tight. You cannot lose vertical on that one. Okay. I mean, we'll cover that at a different time. Like not every sticky bone that me and Dr. Jin make is the same quality. Absolutely not. Socket grafting, case that's like this here you did here, right? I don't want it too dense. I don't want it too dense. I will overgraft it, make a dome, but it's going to be like a D3 type softness. Yeah. Okay. Wonderful. You guys, let's go back into right here. We're gonna wrap it up. Okay. I hope you guys enjoyed today's session, everybody. Okay. Hope you guys had a good time, and I want to give a thanks to our friends here for coming. Okay. We had like almost 30 or more doctors joining. Today I enjoyed it a lot because it was casual. You know, it's casual. A lot more fun than me by myself. Going through a late night coffee show. So you know what, Nekky Jamalian, the one and only, the wisdom tooth guy, who will be also teaching at the upcoming Module 3, the PRF workshop, and also the second day, you'll be teaching the second day with Dr. Sangwoo Ham, the socket man, for a traumatic and socket grafting hands-on workshop, right?
I have the honor of teaching with
There you
the
go.
Sangwoo Ham.
I have the honor to teach with him. You know, we're gonna have fun. We're gonna have fun. I think, to be honest, I can honestly say, to be honest, sorry, Dr. Kwan, but this is my favorite module because I'm with Nekky. It's gonna be fun. It's gonna be fun.
And you know what's monumental is it's going to be our first actual hands-on, physical, on-site, full-blown, workshop since the pandemic, isn't it? Since the So this is gonna be, we're very excited. We're very excited. We rented a big ballroom at a hotel, costing me a ton of money, but it's okay, right? It's gonna be a lot of fun.
It's for Nekky. We're treating Nekky.
That's right.
Nekky. Okay? And
I'm gonna wear a suit and everything.
That's right, man. That's right. So those of you want to join the 2 full-day weekend course, learning sticky bone, venipuncture. I think Nekky's got one of the best venipuncture technique, teaching. For those of you who are scared to do venipuncture, Nekky got you covered, okay? And also extraction and socket grafting. Second day is a 2-day weekend module. I think we still have a few spots left here, not a lot, okay? So you take those opportunities. I highly recommend it. It's this coming weekend, right? Next weekend, Friday and Saturday,
Next
correct?
weekend.
Yeah.
Next weekend, yeah. So if you want to find more about it, okay, email graceinfo@biteinstitute.com, okay? So you guys, thank you very much for tuning in. Nekky and Sang, thank you so much for tuning in as well.
Thank you for having us.
I'll see you guys. Look forward to this coming weekend. Take care, okay? And safe trip flight to Vancouver, Nekky, all right? From your hometown. Take care. Bye-bye.
See ya. Bye.
All right. Okay, let me go right here now. Okay, my friends. Okay, hope you guys had a good late night coffee show today. 2 special guests is always fun. Today was a little different. I apologize. I know. I think I was having a little too much fun. A little bit stepping outside my myself, because Nekky and Sangwoo are like my little brothers, and I'm so proud of them. And they're doing very well, very successful. But we go back a long way, and without Nekky and our faculty doctors like Chris and Sangwoo, and of course one and only Bernard Jin and Dr. Albert Louis, and I've been very blessed surrounded by incredibly talented surgeons and educators, and I've learned a great deal over the last 20 plus years. So I just wanted to share that special time with these boys, and I hope you guys also had a fun time as well. Okay, all right. And once again, thank you so much for joining this evening. I'll give you a verification code for today if you want to claim your hard-earned 1CE AGD credit. Okay, it is LCS Bytes 019 Socket Man. Okay, all right. LCS 019. Okay, right. LCS 019 Bytes. Okay, Socket Man. Okay, so I'll write that down later for you. Okay, and then you can get that 1CE AGD, and Grace will send that to you. Okay, thank you so much, everybody. Hope you guys had a great time. All right. Thank you, Chris, for joining. Thank you, Dr. Jin. Thank you, Easy. Hope you guys have a wonderful Sunday evening, and look forward to see you again next Sunday as well. Okay, take care, everybody. Take care. All right.